The traffic flow, as you see, so the patient in, patient out is only in the operation theatre, and the other disposables are on one end, and scrubbing and the staff personnel are on the one end. So this needs not to be mixed. That is, we have to avoid that mixing of that. Ventilation has to be proper. You have to have a ventilation here, and the air is sucked in and comes out with a HEPA filter, and we have a whole board, electronic board, which tells us how much the humidity is, how much time has elapsed, and all that thing can be done. So temperature and humidity charting on the electronic board, or you can have normal thermometer, but it's preferable. These are not very expensive add-ons, and you can do it. So ideally the operation theatre should be 1 degree cooler than the outer area, only 1 degree cooler. Some operation theatre we see are very chilled. That's not advisable. The air is filtered, air comes in and it circulates through a HEPA filter on the patient, and it goes out from these areas and it is filtered and comes back. So this is the filtration or of the OT and of the HEPA filter. The HEPA filter is on the table, so you get the clean air on it, and the lights are there. HEPA filter is behind this, and then you have this surgical light, and the HEPA filter should be 0.3 micron diameter with the efficiency of 99.7%. There have to be some emergency signals, and these are activated inside each operating room. The light should appear outside the door as soon as the operation starts. The signal should remain or until the alarm is turned off, and all personnel should be familiar how to send these alarm signals and use the alarm system. The clean and dirty linen areas are separate. So the dirty linen goes to the dirty utility room and then out, and the clean linen comes from the clean corridor into the clean area and then goes into the OT and does not mix with the dirty linen room or the dirty linen. The patients will enter the department from the hospital corridor via the transfer bay in one trolley, and then they are transferred to the other trolley, which is the sterile trolley, or which lies in the holding bay. From there they are taken into the waiting area or preparation area or pre-anesthetic area, and from there they are moved into the operating theatre area. That's how the ideal thing should be there. The instrument and equipment will come on sterile trolleys like that, and they are stored in the area outside where the instruments are stored, ultraviolet light or clean areas. So that is how the packaging is storing, and they come packed from the central sterilization unit, which has to be separate. If you have a sterilization unit right next to the OT, it should not, the gas or the steam should not filter in. Then of course each should have a doctor's room for filling up the notes, and where the doctors can rest, and the doctor's toilet is separate, and this is not the scrub room. The scrub change room is outside. The scrub change is not done in the toilets, please note that. And this is here where the notes, and they relax and they can have a coffee or a tea in between surgeries. So this is required for there. Then of course the anesthetist room, which we showed you there, where the pre-anesthetic, sometimes they are induced there and then brought in by surgical trolleys to the operation theatre. The operation light is your, see, if you don't have vision, so you should have 2 5-dome light and 2 moving ones. So one can be focused from here, one can be focused from here, or it can be shifted right straight away. So good lighting is very, very essential for any operation theatre. To eliminate shadows, we have this 5 dome lights which can be again changed. The anesthetist scavenging, you have a circuit like here. The system draws out the theatre anesthetic gas or agents leaking from the circuit, and we have the air filter right next to it. So if the gas is leaking, it goes right out, does not go into the OT gas area. You have to have a swab rack, and the swabs after use are just hanging here, and after the operation they have to be loudly counted, at least 10 swabs, because everyone has a different protocol. we follow the 6 swabs sterilized in the cesarean section set and another in the set of 6. So, you can follow set of 6 or set of 10s. I think more than 6 are not usually required. And this swab rack will take all the swabs after the surgery, and the nurse will do the swab count and put it on the board, and then after that swab count correct, we'll put that way.